We're live in 5, 4, 3, 2, 1. We're live, sir.
Okay, thank you. Good morning, everybody.
Good morning.
Hi, Vasu. So, welcome to the September edition of the Elizarov case discussions. Today, we've kind of got a sort of themed topic in terms of the fact that we are going to be discussing mainly deformity cases. As usual, we have Dr. Vasudevan with us as a mentor. Dr. Hemant Sharma will be joining us in a bit, and he will be giving a mentor talk on fixator-assisted internal fixation. So the speakers today are Dr. Jeejesh Kumar from Calicut Medical College, Dr. Yogesh Vaghasiya, who's working with us currently as a fellow in Mumbai, Dr. Vikram Khanna, who's in New Delhi now, was a fellow with us earlier, and Dr. Divya Ahuja, who's my associate at Mumbai, will be speaking. All of them are talking basically on topics related to deformity correction. As it turns out, all of them are talking about the tibia. So let's start with Jeejesh, who's going to talk to us about a distal, a proximal tibial deformity. Go on.
Sir.
Jeejesh.
Yes, sir. My screen is visible, sir?
Yeah.
Yeah. So good morning to everybody. So today I am going to discuss a case of severe proximal deformity of tibial deformity correction. And during this correction, I have faced some problems. This is what I want to share with you. So this case was done around 10 years back, immediately after finishing my fellowship with Dr. Mangal Parihar, sir. So coming to the case. So this is the case. Patient is 32-year-old man presented with complaints of left knee pain and deformity of left knee and shortening of leg. And there was no history of trauma or any other history, but there was a history of childhood infection at knee, following which all this deformity developed during the growth period. So clinically, he has got genu varus, internal rotation deformity, genu recurvatum, and shortening, and there was a post-polio residual paralysis on right side, and he has got tenderness on the medial joint line, and range of motion was also restricted, and there was no neurological deficit on that left side. And this is his gait, where he was initially used to walk with a single crutch or hand-to-knee gait. Because of the severe pain, he has to use 2 crutches, and his walking speed also was reduced. So you can see this clinical picture and the gait. And these are his clinical picture where you can see the range of motion and the internal rotation deformity as illustrated. And these are his X-rays APN later, where you can see the severe deformity of proximal tibia, or there's genu varum and recurrent deformity in the proximal tibia. And I further evaluated to know the deformity properly, to do a 3D CT and to understand more about the deformity. So how to proceed this case? As this is a deformity case, you have to assess the deformity properly, then for plan a deformity correction. So for the deformity assessment, you have to do the Malay test, and you have to draw this mechanical axis, and these are the values, and you can see that the mechanical axis deviation, that is MAD was 13 centimeter, MPT is 45, and there is LDT is 109. And in this X-ray, it is very difficult to do this because there is a severe rotational deformity So it is very difficult to draw the distal joint line. And there is apart from that, I could find a joint subluxation also about 1.5 centimeters, as you can see here. So centers are at different level. So anything more than 0.3 mm is joint subluxation as illustrated here. And the lateral view also revealed, you can see the recurvatum of about PPT was 96 and the internal rotation of around 45 degree. So altogether, he has problem of varus 45 degree, recurvatum of 15, and internal rotation deformity of 45, shortening of 6 centimeter. And another thing is the problem I notice is a very severe sclerotic bone on that thora level, and there is subluxation. So problem faced during the planning was, which I told that difficult to draw these lines and find out this deformity properly, as there is a rotational deformity also. So how do you proceed in this case at this stage? So as I told, deformity planning is important. Then you have to correction planning is needed. Then which implant I am going to use, whether I am going to do acute correction or a gradual correction. So here, obviously, as considering all these deformities, I would like to go to the Zilizaro as gradual correction. So this is a planning where you can see AP and lateral X-rays, where you can see the cora that is at the proximal region where the varus angle was 45 and the sagittal plane recurvatum deformity was 15 degree, as you can see here. So if I do an osteotomy at the cora, that is that is at the sclerotic region, it is very difficult to do there. So we have to plan according to that. So obviously, after seeing all this, analyzing these options, only available thing is the Elizaro, and you have to do either Elizaro alone or you have to a 6-axis system. So since it's a both plane deformity, you have to plan as I plan for a Elizaro. So do a oblique plane planning here. You can see the plane of deformity and the hinge position perpendicular to the plane of deformity. So to decide osteotomy, a hinge direction, which I told along the oblique plane direction, the osteotomy site is in the proximal metaphysical at the cora. But since the problem I noticed this about the sclerotic regions, I decided to do the osteotomy below. So here then the osteotomy rule number 2 has to follow. And this was a paper tracing that time. Now you have the Bone Ninja, you can do this, all this planning. So these are the difficulties. If we plan to correct the deformity completely, there is a large chance of large protrusions on the medial side, which can cause problem while correction. So I decided to do maximum correction possible in first stage, then planning to a residual deformity correction at later stage. So applied the Elizaro as according to the plan, a pre-constructed frame applied with the hinge position in the oblique plane, and the osteotomy was done below that. So my osteotomy was just above plan, but because of some problems, I could do osteotomy below. And another thing was a problem faced was difficult to pass these wires because of the sclerotic region, and it is very difficult to pass the wires. The wire was deviating, so somehow I managed this case. And while applying, another thing was after the application Elizaro, I was planned to the X-support. And another thing was I could not apply this X-support struts because severe rotation as well as the severe varus deformity, the struts pull out occurs. So I decided to do a partial, correct the partially, then I apply the X-support, what are the residual deformities. So I did according to that, I applied the X-support after the partial correction of the deformity. So as I told, why not X-support initially? I already told the reason, and another reason why I noticed was if there is a chance of region issue if you correct the rotation. If I do all the correction with the Elizaro, then I do only the rotational issue with the X-support, there's a chance of region issues you can expect. So I thought of leaving some residual deformities there plus the rotational deformity. So partially corrected, then I applied the X-support. As X-support was the XSS system that time available. So this was the planning. This was has got a inverse program. As you already know that X-support has 2 programs, standard program and an inverse program there. So in inverse program or any program X-support, you have to take in a proper AP and lateral X-ray with the rings. You have to see as a single ring, as you can see here. Then first thing is to find out the fulcrum, where I am going to keep the fulcrum. To that, you should know the ring center. So to find out the ring center, you have to draw the line along the ring as well as the an oblique line along the balls attached on the either side of these rings. So from the center, you have to draw the fulcrum down and wherever it is. So both in AP and lateral, you have to plan according to that. Next thing is a command adding, that is varus correction. You have to do the whatever the correction you have to add in the expert software. That is here it is varus, so the right side up, and the recurvatum is anterior down, and inner rotation is anterior left. So these commands we have to add. So this was corrected here, but there was another problem occurring during the which I expected. So severe pain occurred because of the stretching of the skin, because of the severe protuberance of this. So I stopped that at that level, and then I told the patient to do the residual deformity at later stage. This was a clinical picture after the removal of the first stage. You can see the full length X-ray. There's a residual deformity and the mechanical axis deviation you can see here. And this is a gate where now, after this correcting this much virus problems, he has all symptoms subsided, and he could walk normally without any pain. And then I planned to after 2 years, plan for the second stage correction here, as you can see here. And the MPT was that stage was 66 and LDT was 101. Now the rotation also corrected, so the LDT I could throw properly. So SUV applied. So this time I could do the osteotomy above near to the first thing. So the translation which I expected was less. And this is after correction of SUV removal. As you can see the X-rays. And here mechanical axis little medial because of that is this one joint subluxation, as I already told here. As you can see here, there is mild subluxation, but that 1.5 centimeter is reduced to less than around 0.5 centimeter. And this is after full correction. As you can walk properly with the 2 crutches, as well as you can see that he can walk hand to knee gait without pain. Is normal pattern resulted. Then this down you can see the pre-op before correction video. And I could achieve total time duration of 6 months in first stage and 6 months in second stage. Here biology is not disturbed by applying this Ilizarov gradual principle and no pain at the knee. Some tips which I follow here: apply the pre-constructed frame by pre-operative planning is important. First thing parallel to the ring, then you hinge at the cora, remaining rings perpendicular to the mechanical axis. And you can proximally, I use 3 wires and 1 shank spin. And osteotomy, you have to find out which site and you have to follow the osteotomy rules. Another, you can, if it is cora is at the joint or near to the joint, you can use this type of hinges, that is extra-articular hinges, you can make like this, and that also you can apply. So in gradual correction with Ilizarov, larger deformity, always you have to keep in mind that structural risk and bonnet risk. That is acute correction, these neurology vascular structures at risk are you have to keep in mind. And this, by doing this you can minimize the injury to the periosteum also. So you have to follow, which I follow this normal alignment you should know. The malalignment test you should know how to do it, then whether to find out whether it is uniapical deformity or multi-apical. And you have to find out where the cora is, and you have to find the single plane or double plane. According to that, you have to plan the deformity correction. And you should know the osteotomy rules here, where I am going to do the osteotomy. Here, my take-home message is: since severe deformity corrections, gradual correction is the best method. Always plan for the osteotomy site and follow the osteotomy rules. In such complex deformities, use 6S system in correction. And if there is severe rotation deformities associated, what I found is you have to recalculate in between rather than correct in single stage. And keep in mind that some 6-axis correction system more than 45-degree angulation, it may not be possible to correct the struts. But in some axis like SUV, you can correct it. And severe rotation deformity correction, always care about the common peroneal palsy. Thank you.
Thank you, Jeejesh. Keep
you.
your slides, or actually just you can minimize or stop sharing. If required, we'll get you to share again. Yeah. So first of all, welcome to Hemant, Dr. Hemant Sharma, who's from Hull in the UK, one of our mentors. Hi, Hemant. So I think this case brings out the most sort of usefulness of the Elizarov method in terms of doing complex deformities where you have angulation as well as rotation with a relative ease compared to the tough job it would be to do this with internal fixation. I personally wonder whether it's even doable by acute correction. And couple of points that you made, which are very important, which first of all is that there is no one plan for these deformity corrections. It's not as if you make one plan at the beginning of correction and then you follow it through till the end. There will always be a little bit of modifications. The more severe the deformity, as things change, you may need to tweak your plan a little bit. So if you had to do this same case again today with so many years of experience under your belt, what are the things you would do differently?
First of all, sir, the planning, always plan according to what I told, the Cora planning, and find out the osteotomy level. Here, I would say gradual correction only I will do it. But instead of, except for now, I have got the SCV. With that, I can do more of precision.
No, I'm talking of a couple of troubles you had in terms of putting on the frame initially. You said the bone was tough. It was difficult to put in wires. They were skiving off.
Yeah, correct.
So how is there anything you would do to avoid that or minimize that? Because one thing I can think of is use largely shank screws.
Yeah, shank screws.
So initially use a couple of shank screws, and then as you get straighter, you can add more fixation in terms of the wires. The second thing was your osteotomy level.
Yeah.
The main reason you had to stop and break it into two was because your osteotomy was lower than what you had planned.
Correct.
And it caused that trouble with the skin. So how would you ensure now the second time around that your osteotomy level is, of course, now you know how important it is.
Yeah, correct.
So you would strive more. So, but any other tricks?
Here, why I could my osteotomy was down was because the two rings was 45 degrees. It was touching each other. It was very difficult to pass this osteotomy and to put an incision with a very little space. Now I know how to tackle it by I will do the osteotomy by putting the incision little laterally, and I can pass this osteotomy and the drill bit I can obliquely along the direction of the proximal tibial joint line. Parallel to that, I can do the osteotomy now.
Okay, and also you can put your ring a little lower. Put the ring a little further away and get shank screws higher up.
Okay.
So that you get more space between your rings, but at the same time your hold is not compromised.
Another thing I want to tell is this, sir, instead of keeping the hinge down, the extra articular hinge if I use, I can have little more space there to do the osteotomy.
Correct. So the hinge is not coming in the way. Hemant, I have a question for you on this. I always find it very difficult to accurately judge rotation when there is a significant angular deformity. And I will give it a ballpark. Okay, it seems like this, but let's see when it corrects out, and then actually judge the rotation more accurately. What is your experience, and how do you sort of deal with that?
So my apologies, first of all, for joining slightly late. So I missed the initial part of the question.
It was a minute late, that's all.
So, but yes, see, rotation in presence of deformity is extremely hard. And so, as Mangal, you pointed out that what we do is we plan it. So what I do is I do all the hip, knee, and foot and ankle supine prone, all the movements. And at that point, I judge the deformity. On the contrary, also, if there is a lot of angulation, even correct angulation can become a bit difficult on a standard X-rays. So if you take a standard knee front X-ray with more than 15 degrees of angulation, probably slightly more, then even your angulation may not be accurate. So I think, and it's no way, unless you do a 3D printing, that you can actually do. So one of the ways to do it is do a 3D printing and then measure from that. But clinically, I do exactly the same, that I measure at best as I can. And then I also warn patient that there would be a second stage, because this is not the most accurate within in severe deformities. And I remember once we had this child from Nigeria, which is neglected infantile blounds, and her angulation was about 80 degrees, the rotation, and we could not assess it. And despite using hexapods, we have to use it kind of two-stage, like Jeejesh, you said that we started off with one, and then once we got a accurate angle, some correction, then we recalculated the deformities and put in the final deformity. My advantage is I have hexapod available to me all the time, so it's easier to do it, particularly rotation, because rotation I tend to do with hexapod and tell patient that we will keep on correcting. At some point you are you feel it's right, we'll stop. Under and over corrected from that point, how you feel. But to coming back to your question, Mangal, specifically, it's extremely hard, and clinically assess as best as we can. CT, I'm not very big fan of, because I don't think it gives a very reliable picture. And then I do it in a kind of two stages, like you do. So sorry, I haven't answered your question.
No, you have. I mean, it's the same thing, that it's not easy to find out, and basically you should be prepared for a relook and a calculation to fine tune your correction. Mota moti, you get it where you want, but then is it 80 degrees or is it 85 degrees? Is it 30 degrees of internal rotation or 20 degrees? That you come to know as things progress, right?
So, another thing I want to tell is once the deformity internal rotation was partially corrected, so the whatever the LDTA was initially was changed automatically, because the X-ray will change, So APL,
yeah, you were measuring the LDTA in a so-called internally rotated distal tibia, and when it corrects, then the real LDTA comes up. There's a couple of questions that you can answer, which are on YouTube before I go to Vasu. Is there any role of CT scan for measuring rotation? That's question number one. Question number two is, was the PDFA normal? And third is there a role of percutaneous release of MCL in such severe cases?
Yeah. So first one is in assessing the rotation. So better assessment is by the 3D rotational profile. You can do it. So you can entire limb you can assess by doing the minimal cuts, that is, or entire limb rotation you can assess, as well as the rotation of the tibia also. You can do either a limited cut, or you can do an entire cuts, entire 3D film of the tibia, so that you can better understanding of the. I have done also 3D CT already done in that case.
Right. So CT does help you to assess rotation a little better, but when you look at the other issues, how your angles change, still you do need, in spite of doing all the CT, you still need to kind of change your tactics a little bit.
Yes,
was the PDFA normal in this?
PDFA is, I think, normal, sir.
Was normal.
Yeah. And regarding the MCL release, so since it's a gradual deformity correction, I have not done in this case MCL release also. So it is corrected. Nothing has happened. So if it is a gradual thing, I think no need to release also.
Yeah. Hemant, any thoughts on the MCL release?
So actually 2 or 3 points, if I can make all of them, Mangal. So one is the CT scan, even if you do so, one of the problems with the CT scan is how it is taken. So you got to be a bit careful, but even if you do a CT, I would seriously suggest that see your clinical assessment and then make a judgment, which is that, and do gradually, because none of the techniques are perfect, and you end up in, especially in the significant deformities, none of the techniques are perfect. So you need to have a sensible approach and a pragmatic approach, that you do a CT, you do a clinical, and then make a judgment and do and prepare to change the plan. And number two, your angles are designed when a bone is straight. When you have the rule, use the rule 2 on is a zigzag and there's a issue, then angles are, you should rely less on angles, more on the mechanical axis, because ultimately what you're trying to do is you're trying to prevent the knee arthritis and varus and valgus thrust. So that way, angles may be a little bit off, but as long as the axis is straight, so total reliant on the angle, where angles on its own is probably not always a good thing. So just to keep that in mind. And Mangal, your question was about the rotation, wasn't it?
Yeah. No. The last thing was the MCL. He asked, Dr. Tanwar asked on YouTube, is there a role for percutaneous release of the MCL?
If you're doing general, if you're doing a gradual correction, then no, unless there is a laxity of MCL and you want to move it after, because in children, after deformity correction, ligament seems to tighten and don't produce any laxity, but in adults, they don't seem to cope with sort of rebalance after the deformity. So in some cases, lateral is easy. By the frame, you can lengthen and the intact fibula and tighten. That medial is always hard. And if you're going to release the MCL, you should be prepared. You should do it in conjunction with the knee surgeon, who's knee soft tissue surgeon, and because MCL, once you have released it, it can be a bit tricky, and the laxity of MCL can cause a huge amount of problems. So in gradual corrections, no, unless there is a laxity of MCL, which should be done with the soft tissue knee surgeon.
Yeah, I agree with that, because what I find is that the femur, distal end of the femur and proximal end of the tibia, they kind of, go in conjunction with each other. And usually our osteotomy, when we are doing these gradual corrections, is distal to the attachment of the MCL. So you don't end up tightening the MCL. So really speaking, there is no role, I think, for a percutaneous release of the MCL. Vasudevan.
Yeah.
Dr. Vasudevan is traveling, but he's still with us. Oh, you're at home still. Okay.
I'm just going to start. See, here, the cases are really interesting. So we must always consider whenever the deformity is more than 35 degrees, so our evaluation can be a little bit erroneous. So as the deformity increases more than 35 degrees, the percentage wise, so as it goes more, we make more of an error. Your judgment, X-ray, everything may not be perfect. Till 35 degrees, your X-ray AP lateral will work. Afterwards, even your evaluation, the oblique plane will come into the AP view and little bit turning that way, this way will happen. So it naturally needs evaluation later on. And as Mangal said, so earlier we used to do osteotomy like Jeejesh did. Now we have more skill to do osteotomy very closer to the cora. And we can you can see that his osteotomy was a little bit sharp on the middle side. So what I do nowadays, I take reverse osteotomy. So the middle spike will go upper end. So there will be a slopy edge there. There won't be any sharp prominence on the middle side. So can Jeejesh show me that original osteotomy side X-ray?
Yes. Yeah.
Yeah. Here you can see the osteotomy was transverse.
Yeah.
Okay.
Yes, like
instead of that, we tend to use osteotomy like this. Just imagine the osteotomy middle side is higher and distally lower.
Yeah.
then
Correct.
that won't produce that much of spike on our subcutaneous skin.
Yeah, this was the planning which
Now you can see that.
So what
sharpness.
he's saying is something like this,
reverse.
in this direction, so that the medial edge is not as prominent. Though conventionally we would say that you got to go parallel to the joint, but in something like this, that's with the kind of experience, we go into a slightly different mode because we anticipate that, okay, this is going to create that problem once we get it corrected.
And that spiky bone is actually of no use and it produces pain.
Correct.
But you are actually saving more bone this side.
Yeah.
Okay. The next thing is you can go higher up. Now we know how to put a shank screw obliquely.
Yeah.
You can get a better hold.
Yes.
And you can use multiple olive eyes. So you can do osteotomy even at that exact near the corner below the tibial tuberosity.
Yes.
In a different direction. So that will give it more cosmetic and a perfect nice correction.
Yes. Agree.
Okay. And somebody was asking about MCL. So here we are dealing with extra-articular deformity. And there's no question of intra-articular deformity. Then always in such cases, you must take a stress view of the knee joint. So I take a 3D CT scan and I personally go to the scan center and sit and plan it on their CT computer. So you don't think that we can do it on the images there. And nowadays I started doing even rotation into the hinges. Because you know the oblique plane is AP lateral, you combine it to an oblique plane. Okay.
Jeejesh, you can stop sharing.
Okay.
So then everybody comes on the screen.
Yeah, the AP lateral you convert it into an oblique plane. So now Jeejesh has come to a level that oblique plane can be combined with another angular rotation. Rotation is an angular deformity around the vertical axis.
Yes.
So you can join these together and keep the hinges in different level and correct it. So now Jeejesh is at that level, you must try on that.
Yeah.
Try to combine oblique plane with rotation plane.
Rotation plane.
So the hinge on the front and the back are what is known as an inclined hinge.
Yeah.
So that you take the angulation and the rotation as two different planes. The angulation is in one plane and the rotation is in a plane which is transverse to that. When you combine both, you can calculate. But
it's of no use now because of the hex supports.
Exactly. That's what it's too much of calculation if you can do the same thing with a hexapod. So what I tend to do is get most of the angulation corrected by hinges so that the time for the hexapod on the patient is less. And biggest advantage as far as I'm concerned is patient just has to turn one nut on the motor instead of 6 struts. So motor, generally you get it into the ballpark and then use the hexapod to dial in all the other corrections that you need.
So that's what I do nowadays. Gross correction with the fine conventionally and fine tune with a hexapod.
That's right. Okay, good. Thank you, Jeejesh. Lovely case which brought out. I think we are going to underline a lot of these points in the coming talk. So the next, I'll call on Yogesh, Dr. Yogesh, to share his screen. So, this is a case that we did, which had a non-union, but there was a significant deformity, and this is one of those cases which similar to the cases which Vasu likes to show. Absolutely outlandish deformity. And so we wanted to get this done close. Go on, Yogesh. Yogesh, I can't hear you. Are you muted? Are you muted, Yogesh? I can see your screen. I can't hear you.
Yes, sir. Sir, am I audible?
Yeah.
Okay. Good morning, everyone. I'm going to present a case of distal tibial deformity with non-union. Middle-aged female patient came to us with complaints of severe deformity and shortening left leg. She gave history of fell in 2017. She fell from 8 to 10 feet height and sustained open fracture of tibia and fibula distal third shaft. Followed by she immediately underwent surgery. External fixator was applied for tibia and K-wire for fibula. 13 days later, fixator was removed and slab was applied. Then 15 days later, slab removed. Query, fracture was healed as records not available. She again gave history of fail in 2018, treated conservatively. Followed by she progressively developed a deformity and shortening. X-ray shows a non-union at distal third of tibia with tapering ends, tibial deformity, recurvatum and varus, ankle equinus, some amount of rotation, and fibula also united in abnormal position with K-wire broken in situ, and foot shows disuse osteopenia. Local examination shows no mobility at non-union site, distal third tibia, varus and recurvatum deformity, ankle equinus, limb length discrepancy due to deformity, no infection, vascularity intact. Here issues are tibial non-union, which has tapered end and severe deformity. So around 80 degree of varus, 90 degree of recurvatum, and equinus at ankle. Here challenges are whether to go for acute correction or gradual correction, and whether to fix it by internal or externally. If we'll go with acute correction, then we have to shorten the bone, and if we'll shorten the bone, then there is a shorten the bone and we'll acutely correct, then chances of neurovascular compromise and a bunching of soft tissue will be there. So here we opted option for gradual correction by external fixation. Another challenge is as the deformity is severe, we have we have problem in placing wires, as there is a 90 degree of bend and rings were clashing. So plan was partly correction acutely and remaining by gradual correction using 6-axis rods. So intra plan was removal of implant, fixator application, fibular wedge excision, and freshening at non-union site. As there is a severe deformity, we pass a calcaneal wire to guide our distal tibial wire. There is a short fragment was there. So in the middle ring, screw was placed more than 90 degree to increase the span of fixation. Here red color arrow shows a 90 degree screw means 90 degree screw position, but we have placed the screw at a certain angle, which shows as a orange arrow, which increases the span of fixation. Then a fibular wedge excision we did. Once fibular wedge excision we did, followed by we mobilized the tibia and fibula fragment separately. This is the post-op X-ray, immediate post-op X-ray. We made a plan for distraction, as we have to distract initially to avoid clashing of fragment and to stretch soft tissues. This is at the end of distraction. Then we made plan for alignment. Alignment correction started. This is at the end of 2.5 months. Then we started gradual compression and lateral translation correction. This is at the end of 4 months. As red arrow shows, there is some callus formation at the distal third tibial non-union site and union between tibia and fibula. This is clinical picture. Immediately it was in severe varus and recurvatum deformity, followed by second image shows distraction. Third image shows alignment correction, and right side image, right side most image shows neutral alignment. This is 6 month post-op. At the time of 8 month post-op, it shows red arrow shows poor cross-sectional healing anteriorly. So we plan for bone graft to improve cross-section healing, and the tendon is released to avoid stress at union site. So bone grafting, we curettage we did, followed by we did bone grafting. Right side image shows equinosis correction as counter of joint congruency is maintained. This is 1.5 month post-op followed after bone grafting. 2.5 month post-op, it shows a nice healing going on at the anteriorly. 6 month post-op. This is the current status of patient, 1.2 year post-op. So learning points are severe deformity, rings not parallel or perpendicular. Osteotomy first, then we have to hold it with, these are the another options. Osteotomy first, then we have to hold it temporarily using wire or pins, and then we have to put rings or using step rings. Principle of Elizarov fixator application. So if a fragment is small, then we can increase spanning of fixator using oblique sham screw or drop wires. Heel ring to correct equinus, fibular oblique osteotomy versus wedge excision. As if we are going to do oblique osteotomy, then acute correction of this much severe deformity not possible. So wedge excision is the option. Pin site care, restriction at non-union site to stretch soft tissue and avoid clashing of fragments. Tendon lengthening to improve gait and avoid stress at regenerate site. And bone grafting to improve cross section of healing. Thank you.
Yogesh, go back to your clinical pictures of the frame.
Yes, sir.
There's no heel ring anywhere.
Here we didn't put, initially we can put heel ring to correct equinus.
Okay, but in this case, it wasn't put.
It was not put, sir.
So the reason for not putting the heel ring, okay, you can stop sharing and we'll get you to start it again if required.
Okay, sir.
The reason for not putting in a heel ring for equinus over here was that we kind of expected that with stretching, the equinus will correct, which happens in most patients. So we were expecting that it will correct, but once she was corrected, it still had not corrected. So when we were doing the bone grafting, we decided that we have to correct that equinus, because otherwise her gait is not going to be normal and she's going to be putting a recurvatum force on that healed area whenever she walks. And that with a percutaneous, the triple cut hemitenotomy of the tendo-Achilles, that came up without any trouble. She's walking without the brace. She's an extremely worried patient, so that's why she continues to wear the brace at the moment. So here, I think the point that was made was that one is, especially in non-unions, the deformity is never as bad as it looks to be primarily, because once we cut the fibula, the deformity certainly improved and we were able to put in the rings as required. Second is, we don't have to go parallel to the joint. What we did here was we went a little sort of angled to the joint. So at the end of correction, instead of all the rings being parallel, the distal ring was in a little more valgus. Can you put on your this thing again? Yogesh, share your presentation. Yeah, go lower down to an X-ray with the frame. Yeah. Okay, that's good. Yeah. So you can see that the ring and the wire is not parallel to the joint. In fact, it is a little angled. So that allowed us to put the ring in easily. But at the end of correction, then we have to use various forms of hinges or coupled washers to hold the ring properly. This case also shows the fact that small fragments, if you use drop wires at multiple levels and multiple angles, you can hold the distal fragment fairly securely. Hemant, how? What do you think of this in terms of?
First of all, it's a cracking case. So, the couple of things is, one is I have a lot more trouble with the tender Achilles and equinus. So what I would have done is I would have put in a foot frame right from the beginning, because my worry would have been that equinus might increase. So that's my one of the worries. So, and I think your trick of putting an oblique ring is probably is fantastic, and you can see you have dropped the ring more or less to the ankle joint. I generally worry too much about when the small fragment is there.
Yogesh, just one sec. Sorry, just stop sharing the screen, please. Yeah, thank you. Yeah, go on.
So I worry too much about small segments, and when they haven't walked that much, that bone may be a bit osteoporotic, and my hold may not be good. So I always, as a sort of default, will take support from the ankle just to increase my stability for the distal segment. But but you managed it very well, and I think so. That's the other thing I will by default to do that. The third thing I would say that I would have probably bone grafted much earlier, as soon as, because the bones are sort of quite sort of tapered, and despite the excision, there was some worry that it may not heal. So as soon as correction is done, perhaps bone grafting right in the beginning at that point would have helped heal probably a bit quicker. I don't know. That probably but I think putting on the ring is probably the hardest bit. And I think part acute and part gradual would be good. And I think acute is probably almost impossible in this case. So gradual would be the case. And again, this is one of the cases where your planning has to be sort of staged, where you plan as best as you can, because and then subsequently you keep on changing your plan. Are you planning to lengthen her, or she's happy with the current situation?
She is equal now, almost, I think. Okay. She's almost equal. She's not significantly short anyways. With the brace, which means probably about 1.5 centimeters of sole, she's walking without a limp.
The other question is, all of you seems to be quite unanimous about doing initial correction with the hinges and then put on the hexapod to decrease the hexapod time. Is there a particular reason for that? Because I thought if you put hexapod right from the beginning, it will just saves you a lot of hassle, makes your life easy. And also because I don't put hinges, so probably I find it easier with hexapod. That may be one of the reasons.
Yeah, so I think I'll answer that. Vasu and me both seem to feel that way. There are multiple reasons for that. When the hexapod came in, we almost stopped using hinges, right? And we used to put the rings parallel and then put on the hexapod. And because I had access to a fair number of hexapods, so I could do 2-3 cases at a time, and all of them on hexapod. Vasu, on the other hand, I think initially had one hexapod, and he generally tended from the beginning to do this deformity correction by hinges. But later on, once I had my, should I say, fill of hexapods, I knew everything that I needed to play with the hexapod. Then I realized that, one, the fellows and other people don't get understanding or feeling of how deformity correction is to be done, because then for even simple varus and valgus, we were putting on hexapods. So it detracts from their learning experience, number one. Number two, which was also important, was that when a patient comes with a hinge, you just have to sort of measure, and the patient has to turn only one thing. Whereas with the hexapod, he has to turn 6. When he comes for a follow-up, I don't have, you probably have, Elixir of nurses and stuff like that. We have to measure all those 6 struts ourselves. And then if one of them is on, off, which usually the back ones, they will kind of turn a little by themselves because the patient is moving around and all that. So primarily from the point of view of education to patient convenience. So now that is what we tend to do, because unless unless the fellows estimate the deformity, create a frame, understand that concept of creating a crooked frame for a crooked limb, I think somewhere their teaching gets dumbed down. They don't learn the absolute basics. So that's one of the reasons. Otherwise, yes, putting on a hexapod is much easier. You don't have to put on the hinges and stuff. So it takes a little more time pre-op. But for the fellows, I think from a training point of view, that is much easier. And for patients, it's easier to just distract on one rod. I agree with 2 things that you said. One is in terms of the tendo Achilles. Okay, if it is going to create a problem. But this lady had a straight foot initially. There was no tendo Achilles contracture. And generally, we found that mild degrees of contracture with the patient stretching it enough, it works out so that they have a plantigrade foot and proper forces are distributed. However, in this particular case, it didn't work out. And the second point which you made about bone grafting early is absolutely valid. This lady also, the plan was to graft her early. She was financially challenged. Her employer was paying for her treatment. And even the second time when we did the bone grafting, essentially, I think we had to cut down her. She was already being done on a concessional kind of thing. We further cut it down because now I said we have to do it. There's no other way. But with that thin bone over there, the point that you make about doing a bone grafting early is absolutely valid. I agree with that. And that was actually the plan which we had for this lady. No point in relying on biology when it's so narrow, but it didn't change. So then we said, now there's no other go for that. Vasu is muted. Now he's unmuted.
Yeah. I think Mangal, you are right. And that was exactly the reason why I was using only conventional Elixir for most of the deformity corrections. And the next issue is when you have a deformity more than 45 degrees, it is very, very difficult for the SUV or hexapod to get connected there.
Yeah.
So in that case, I can use a conventional Elixir to bring it back to a good level so that I can connect it. And my patient won't go home with SUV.
Right.
In 1 or 2 days, I can finish it off. And that spiky projecting rods and all, it was hindering the patient in lying down. They usually try to say, no, remove it, that sort of thing. So usually in 2-3 days, we remove everything, fine tune it and send them off. It's cost effective and as well as patient friendly. And more than that, my fellows are all learning good. I give them more freedom. They can change the hinge wherever they feel like. Let them make all errors. We can correct it at the end. Anyway,
so again, same thing, convenience and education, both.
Yeah. And the case was really fantastic case. And it was done perfectly well. Though now everybody, all the students must have seen that the rules of making rings parallel is only for initial stages and simple cases. As you become experts, you can keep the ring anywhere, but the aim at the ultimate end is getting correct.
Yeah, it's the bone which has to be aligned. and the rings may be misaligned.
Yeah.
It's much more convenient if the rings are also aligned, because then you can use straight rods and all that.
That's
But
right.
when you have a problem situation, then you can modify that to a certain extent, I think.
And even post-operative, if you find the ring is not perfectly parallel to the joint, there's no need to worry about it. We can still correct it, provided the frame is stable.
Yes. So we try our best in other cases, not in this particular, to get everything parallel, because when you do it, 10 times you do it proper parallel, pay attention, 11th time it becomes an automatic kind of thing. So that's fair. Right. So this was a Vasu type of case, where Vasu usually shows, he doesn't show any case which has less than 90 degrees of deformity. So thank you, Yogesh.
Mangal sir.
Yes.
One doubt I want to, it's a common doubt, is because usual teaching is in atrophic non-union, you have to freshen the bone ends and put grafting and docking, then you lengthening. So here this case is almost the atrophic variety of non-union, where the bone ends are sclerotic and thinner. So what what made you to think of a gradual correction rather than the acute correction in this case?
See, to me, an atrophic non-union is something
Jeejesh,
which is
here,
a question.
So we corrected the deformity first,
Correct.
and then we found it is healing well.
Correct, sir. But
So the other one is a non-union treatment. Here, what was the treatment given was not a non-union treatment, no.
it's only deformity, and then
It's a deformity treatment was
so.
Yeah,
Hello.
but so what the other
given,
thing is,
and the situation is
atrophic meaning is to me that there has been damage to that area. There has been damage to that biology. Now that damage may be either because of a severe fracture comminution. That damage may be because soft tissues were damaged. Now this lady had nothing of the sort. So only her edges had become a little sclerotic. So as Vasu pointed out, anyway, I needed to get this straight. Once it becomes straight, if it is showing signs of healing, then I can afford to wait and watch. But again, as Hemant pointed out, in this particular case, it may have been easier or better or correct to do a bone grafting slightly earlier to augment the cross-sectional healing. Otherwise, biology-wise, in that narrow area, she did heal pretty well. So this whole issue of atrophic is a little gray area as far as I am concerned. It doesn't necessarily mean that you have to always excise. After, for example, after you've excised the fibula, if this is not moving much, then it's still a stiff non-union. Though on X-ray it looks a little atrophic. If it's not moving more than a jog, then it's a stiff non-union. And therefore, we try to correct the deformity. Worst case scenario, once we have corrected, we find after 4 weeks, 6 weeks, there's no bone formation. Then yes, you might have to change your plan.
Okay.
Anything to add to that, Hemant? You're muted, I think.
Sorry, yes. Jeejesh, I think if you see anatomically, the concept of atrophic non-union actually doesn't exist, because the initial classifications were put on the basis of vascularity, that hypertrophic non-union has a lot of vascularity, but there is a lack of stability and therefore throws a lot of callus. And atrophic non-unions do not have a vascularity. There are subsequent studies, especially from Edinburgh, from Hamish Simpson, his group, and they have done the biopsies of the atrophic non-unions, and they have found the vascularity is there. It is just the manifestation is delayed. And that is for a number of reasons we don't understand very well. So I think the whole concept that atrophic non-union is more of a convenience of us describing what it looks like rather than the actual biology. And therefore, as Mangal pointed out, that if you have, so is the only way you can assess is once during the fibular osteotomy, If you check it, and if it's still just a jog of movement, then your chance of healing are much better, and there's a possibility you may not need to bone graft it. But if it's all over the place, it's moving in the wind, then all that comes through. And often we excise atrophic non-union type is because to get the wider bone ends, to get the good healing area for patient to bear the weight. Because a thin healing is, the risk of refracture is there. So you excise it, bring it down to the wider surface, so that works better. But as a concept, if you look at it biologically, then you don't have to rely on the bone ends to describe the biology for you.
Yeah, the atrophic and hypertrophic non-union classification is based on radiology, not on biology.
Yeah, I agree. It's not everything that looks atrophic may not necessarily be. And here again, a similar point which we said earlier of rethink. You know, there is no one truth. You are distracting it. You think it's hypertrophic. You distracted it, and then it's not showing enough healing. Then you have to take steps to do the biology. You could be wrong, but when you see enough of them, you tend to get a little better at identifying, okay, this guy is probably going to do well. One of the upcoming ones, we'll have a couple of these hypertrophic ones. Great. So now I'll call Vikram.
There's one more point, Mangal.
Yes, Vasu.
Yeah, the hypertrophic non-union, if you don't treat it, usually there are two phases for hypertrophic non-union. One, either it goes for malunion in that position, or
yes,
it grows onto synovial pseudarthrosis.
Yes.
In a case of synovial pseudarthrosis, if you distract it, the X-ray ways it look like hypertrophic non-union, but it won't throw bone.
Correct. Yes, because it's not fibrous tissue and it's synovial tissue, and that's not going to metamorphose into good bone. But usually you will get a reasonable idea about that because it will tend to be a little more mobile once you excise the fibula and things like that.
Yeah.
So the point is that on X-ray, it looks as if it's hypertrophic, but if there is a synovial cavity between the two, then it's not going to behave in the same way. Right. So now we'll call on Vikram. Vikram is in disguise today. He earlier used to have a beard. Today he's clean shaven. Are you becoming an arthroplasty surgeon?
No, sir.
Okay. Arthroplasty surgeon, clean shaven, wearing a tie and all that, you know, those are signs of someone metamorphosing into an arthroplasty surgeon. So Vikram is going to share a case which was done at Mumbai while he was a fellow with us. So he was involved in all the planning and the follow-up of this patient. So
Vikram, before you start, don't believe that. You're looking pretty good. Carry on like that.
Thank you. Okay, good morning, everyone. Thank you, sir. Today, I'll be presenting a case of bowing deformity of both lower limbs. The patient presented to us with bowing deformity of both lower limbs, which he noticed first in the infancy. He was diagnosed as hypophosphatemic rickets, and there was a history of guided growth surgeries, both for tibia and femur done. On examination, he had bilateral varus alignment with varus thrust with the tibial intorsion. He had a shortening on the left side by 2.4 centimeters with a waddling gait. These are his clinical images, and from the front and the back, we can see the incisions of the scars of the previous surgery, and there is a Coleman block method to identify the amount of shortening. The thigh foot angle has been taken for the measurement of the tibial intorsion. On the gait pattern, we see that there is a varus thrust, which is more prominent on the left side. X-ray scanogram weight-bearing films, AP and lateral, show the typical bowing presentation. On the lateral side, however, we can see that there is procurvatum deformity on both the femur, which on seeing the true lateral view, we can identify it's just on the right side, not on the left side that much. Then stress views were done to identify any ligamental laxity. The plan was first to correct the biology of the bone by the management of the hypophosphatemia, followed by staged correction. In the first stage, bilateral femur double level osteotomy with nailing was planned. And once the femur united, then stage 2, by both tibia double level osteotomy with nailing or Elizarov assisted correction was the plan. So for the left side, the femur was taken up first, and the TraumaCAD planning and templating software was used to identify the level of osteotomies. And the HKA was found to be 142 with the target LDFA and MPTA as 90 degrees was kept. So with the help of this TraumaCAD software, the templating was done and the osteotomy was carried out on the X-ray, and we tried to put the nail in by these yellow lines show that a nail, intramedullary nail fixation, and it seems to be going pretty well to the proximal end of the bone as well. The lateral side doesn't show much procurvatum deformity. So now execution of the plan. On the C-arm we use this protractor and we measure the angle of the guide wire, and this angle, the direction of the guide wire is also maintained with the help of polar screws, polar wire. Since the osteotomy was planned above the level of the cora, so we decided to go with Osteotomy Rule 2, and hence translation was, the fragment was translated, and then the straight reamer was progressed proximally, and then it was angulated to correct the bowing deformity. Now, this was followed by passing the guide wire, and as soon as it hit the next cora at the predetermined level, another osteotomy was done. Again, the straight reamer was passed in and angulated to correct the deformity. And then after that, guide wire was passed, sequential reaming was done. And at all times, the osteotomy was reduced by angulation so that the deformity and the alignment was corrected. Then this was followed by the insertion of the nail. This is the immediate post-op X-ray showing the nail in situ and the deformity correction. After 1 week, we had planned for the operation of the right femur. The right femur, again, TraumaCAD planning was used to identify the levels of osteotomy and then the target MPTA and LDFA was kept to be 90 and 88 degrees respectively. This X-ray image shows the level of the osteotomy plan. If you can see that the cora is down below, just above the notch at 6 degrees, the dotted line. However, since it was not possible to do the nailing, putting the cora there, doing the osteotomy there, hence we did it a little proximal to that, and again Osteotomy Rule 2 was applied. So this is the X-ray with after templating, after the osteotomy. We put in the nail in. These yellow lines depict the nail, and we see that in the AP view they are going perfectly fine. However, in the lateral view, it's not going all the way up. Then we also used the TAP plan. That's an online 3D planning software to do the planning of this for the femur, because we were not getting adequate correction happening with the 2-level osteotomy with the TraumaCAD, especially in the lateral view. So here the advantage being that in this we could there are specific markers which are applied during the X-rays, which convert the X-ray into a 3D image, and then we can visualize in AP and lateral view by keeping the osteotomy at the same level. So as expected during the in the intra-op period, the initial 2 osteotomies were done at the same technique as the previous on the left side. However, in the right side, a third level osteotomy had to be done because the straight femur was hitting on the anterior cortex in the subtrochanteric region, and so another third level osteotomy was done, and with the help of the hammer, the angulation was corrected and the alignment was corrected. Now, after that, the guide wire passed easily, sequential reaming was done, and the nail was put in. This is the post-op X-ray showing the triple level osteotomy with the nail in. The osteotomy is united in 6 months' time, and after 10 months, you can hardly see the osteotomy lines. However, at that time, we had planned for the tibia correction, and this is the pre-operative work. Left tibia planning, as you can see, when we did the trauma CAT planning on the full length X-ray, on the left side femur is undercorrected at 95. So the LDFA is 95 degrees. So the target MPTA we kept as 90 for the osteotomy because we had planned with an Elizabeth. So we thought that at a later date, if we want to increase the HK, then we can do it with gradual correction only. So just to identify the levels of osteotomy and the cora, we kept the MPTA as 90 and we got the levels of osteotomy. Then this was followed by a reconstruction of frame with hinges, with the hinge kept just lateral to the lateral cortex. Both level, double level fibular and tibial osteotomy was done and the frame was applied. These are the post-operative X-rays showing, and the clinical image showing slight internal tibial torsion, which was not corrected at that time. After 1 week, the right tibia was operated. At that time, we had on the full length X-ray, we saw that the LDFA was 89, so we used the initial pre-op planning only for the tibial frame calculation. And this, as you can see, that the distal angle is not too much. So in the intra-op period, it was decided that we will do acute correction of the distal osteotomy, and we applied hinges to the proximal, between the proximal two rings for the gradual correction. These are the immediate post-op X-rays. We can see the distal osteotomy has been acutely corrected, and the frame has been straight connecting rods have been applied. The left tibia, once the distal osteotomy correction was complete, we had applied ortho SUV frame to correct the tibial intorsion. This 2 such programs of 10 degrees correction were made, and they were done in an accelerated form. Within 2 days, 20 degrees of correction was done. This is the post-correction clinical image showing that the rotation has been corrected. Here we see once all the deformities were corrected, we took a full-length X-ray and then changed to straight rods. This is the patient walking comfortably with both the tibial frames, and this is 11 months post-operative time, and the frame was kept on a little bit longer because the patient was outstation, and due to corona, he was not willing to travel and come to the hospital sooner. And the other thing is that now, after 11 months, the osteotomy seems to have united pretty well. However, on the left side, where the rotational correction was done with the ortho SUV software accelerated, there the distal osteotomy quality, regenerate quality doesn't seem to be particularly good. This is the pre-op removal of a clinical image showing the just before removing the frame. Then after the stress test, we removed the frame and applied a below knee cast. After 2 months, everything was removed, and this is the final picture of the X-ray, final picture of the alignment of both the lower limbs. showing that the angles are pretty in the normal range on the right side, LDFA and MPTA. However, on the left side, the LDFA is undercorrected. To compensate for that, the MPTA is also a little higher, but the HK is within normal range. So the learning points which I learned during the planning and the execution of this case was that there is an importance of pre-operative planning, especially for the femur, because we have to identify the levels of the osteotomy and we have to work through it. Execution of the pre-op planning is important because we can plan anything on the system, but we have to be, if it's not executed properly, like I feel that on the left side, left femur, we lost a bit of reduction while reaming and reaming or nail passage of the nail. So that is also important, that execution should be well. Use of more poorer wires or screws for maintaining good reduction for nailing, that can be done because as the left side remained undercorrected a little bit. So if we would have added, instead of one polar wire, maybe two polar wires with a passage in between for the reaming and the guide wire and the nail insertion, that might have been a better bet for maintaining good reduction. Then use of triple osteotomy in this case was a necessity because the straight reamer was hitting on the anterior cortex, so we had to go ahead with it. But eventually, I think that on the right side, we were able to control the reduction and the alignment better with the triple osteotomy instead of the double osteotomy. In addition to it, we could have used fixator assisted nailing, but then it's technically more demanding. Difference between anatomical and mechanical access from the entry from the distal femur may affect the level of osteotomy. Because we have done all the planning using the mechanical axis of the femur, and that entry point should be slightly medial to the notch, and when the nail enters, that goes through the notch. So I think that there is some mismatch going on. So the osteotomy level should be a little lower. Then the presence of sagittal and rotational deformity may alter the deformity assessment and quantification. In the right side, there was quite a bit of procurvatum deformity, whereas there was a rotational element of deformity in both the lower limbs. I think CT would have been an asset in such a case, but again, the radiation, so the cost, so the benefit is questionable only then. Use of hinges for gross correction, followed by 6-axis device for fine tuning, as Sir has pointed it out, that it is very easy to do the correction for the patient to do the correction with the hinges rather than putting 2 6-axis devices in the proximal as well as distal osteotomy site in the femur, in the tibia. That would cause massive confusion. Then regarding the left side tibia distal osteotomy site regenerate quality, I think gradual correction of the rotational deformity would have been a better bet. Or we could have divided the rotational deformity in the proximal and distal tibia instead of just keeping the 20 degrees for the distal tibia. So that might have improved the quality of the regenerate. Thank you. This is the image which I added. This is on the left, we see if we do the planning with the anatomical axis and we keep that axis to the medial to the notch, then we can see that the osteocora is at a higher level as compared to the cora if we keep it through the notch. Thank you, sir.
Great. So on the right side, did you do a deformity rotational correction or not?
So we did it in the distal osteotomy site acutely.
Okay.
Yes, sir.
So it was done, and then there was no additional rotational correction.
No, sir.
On the right side.
No, sir.
Okay. Good. So I think that is a good exposition on. We get a lot of these patients, and this is a standard way that we do it now. where we do the femurs with a nail and the tibia with the fixator, so that we can then balance out whatever is required. You can stop sharing, Vikram. If required, we'll get it shared again.
Yes, sir.
So let's get, if Vasu is not traveling as yet, let's get Vasu's thoughts first.
I'm traveling now.
Okay. So we'll
maybe I'll reach there. In between, join.
Okay. So Hemant.
So, so quite a few points I thought I'll make, and some of them.
First, let me just ask you: do you see a lot of these hypophosphatemic rickets with bowing deformities?
Yeah, we do.
Yeah, okay.
We do. We see quite a lot. We don't get any nutritional. I've done quite a few hypophosphatemic rickets, and even during my fellowship in Belfast with Michael Laverick, he was a pediatric surgeon. Most of his, well, all of his, 100% of his adult and pediatric population both were hypophosphatemic. We didn't have any nutritional rickets at all, not even one.
So that means that despite you probably, I would say that over there will be early recognition, early treatment. Despite that, in hypophosphatemic, deformities do occur. It's not related to how well or how early they are caught. So
one of the problems is that maintaining the phosphate level, and that's probably the issue. So they have found they have had a new drug which is quite expensive. I've forgotten the name. Actually, my pediatric colleague, we just was speaking to him last month, and that can maintain your phosphate level quite well. And so we have it generally runs in families. So I have a family with about 4 children, all having the same problem. 2 we have corrected, and 2 are actually quite well maintained with the what do you call that, with this new drug. So, but it's only I completely forgot the name of it. But so that's one thing. But it's a huge problem because patient compliance is an issue. And one simple good thing is, if you take Coke, let all the gas run out, set it for a bit, and let them drink. That's very high in phosphates. So that's
okay.
So that's an easy way which children will drink. So Vikram is a very good case. These are the kind of case we get more often rather than the previous 2 shown, because. So one thing I want to point out was that I'm sure you know this, on trauma CAD you have your calibration marker, and there's implants as well, so you don't have to draw lines. You can actually put a nail of whichever company you want on it, and you can have the size and everything on it, and it will give you very good calibrated image, so you know exactly I'm going to use size 10 or 11 nail or whatever. So it is available to you free of cost on that. The other thing I would say is that when the nail entry point is a big issue, especially whether you do fixator assisted or without fixator assisted. One of the ways to look at it is that you correct the deformity on the trauma CAD, and then take all the lines off, draw a straight line intramedullary, and you will know what your entry point is, because often your entry point is actually moves once you've corrected the deformity. And people who do not have a trauma CAD, what I used to do in the past was I print a page from the PowerPoint, cut the bones, put some sticky tape on it, and then draw a line. And then basically you will know where your entry point is and how much you have to move or translate to correct the deformity. And I used to stick those paper in theater. Very simple way, but much easier because trauma CAD is not available to everyone. On the same note, OrthoFix has a free software. It doesn't apply multi-level osteotomy, but it's free of cost. I mean, I'm trying to get them to make it available as a standalone, but I'll speak to them, and if required, if they're happy, then I'll pass it on to Mangal, who can distribute to everyone. So you have a free access to a software which you can plan angulation, etc., who don't have trauma CAD. It is actually a good example where you don't rely completely on angles like we were discussing. So we often have undercorrection in femur with the nail despite all our efforts. And then what you do is putting on a frame is easier because you can easily ignore the angles and correct your alignment and axis so that your mechanical axis goes from the center of the knee where it goes. So it's a very good example of that. The other point which I've sometimes found is that polar screws can be a problem. So polar wires are commonly used. I would suggest using a DHS wire. And the reason for that is when you're putting in a reamer, you will find that your wire can break. And if a wire breaks, there is no way of taking it out. DHS wire is pretty sturdy and it's unlikely to break, and you can take it out later on if you don't want to leave it. Because that's the reason people use polar wires rather than the screws. All in all, I think it's a very good case, which actually this is so critical that pre-operative planning is so important to get your results, and which is shown very well that pre-operative planning, how important it is. Multi-level correction with fixator assisted can become very tricky because none of us have straight reamers. So the problem with that is you correct it and you have to have straight reamers, which is ideal. Although once you correct it, you can use the fixator assisted, you can use the flexible reamers. Usually you are okay, but you can struggle. The technique you use, what you use in osteogenesis is imperfect. You just keep on reaming and putting it through, and then where it hits the bone, cut it, push the nail further. So it's a good technique, but you can't put the right size nail because the multi-level osteotomy, you always end up putting a smaller size nail. The other thing I would suggest is once you put the nail on one side, just try to compress all the osteotomies, because when you have multi-level osteotomies, one of them have to have a tendency to delayed union or non-union. So you end up with a bit of a problem with that. But overall, I think it's a fantastic case with very good pre-operative planning.
Thank you, Hemant. So now that once Corona is over, the next time you come down to India, I know you keep presenting people with TSF frames. So I will present you with a set of solid reamers. That's the advantage of being in a what do you call low resource country. But that is something that has always been on our table for exactly this reason, that using the reamer you can direct exactly where you want to go, which you cannot. So once we've gone in then and kind of got it to say 8, 9, 10 or maybe 9 usually, not 10, then we will put in the guide wire and use a powered reamer to ream it out for the length of the nail that is required. And actually over time, I think we have got gradually a little better at understanding and doing these deformities, in terms of the accuracy. But as you pointed out, despite all of the tries that we make, we've always lagged a little. We tend to undercorrect the femur. Now, with one more osteotomy, that is 3 osteotomies, in the last, I think 3 or 4 patients, we have tended to be more accurate. So I think what is happening is that there is a certain element of proximal femur varus, which tends to throw it off, because your nail has to go right into that, towards the region of the piriformis. So that last osteotomy, which is most proximal, is kind of critical. We get everything else right. The entry point is fine, everything is there, but this hip is in a little bit of varus. If you don't correct that, your overall numbers remain kind of this thing, remain a little narrow. A little less than what you wanted. So we always then use the LRS or the ring fixator to compensate for anything wrong that we may have done. Jeejesh, you have any thoughts?
No, sir. So similar case, I have done one case like this, sir. So here also I did double osteotomy by planning and anatomical axis planning. So what I found difficult was the positioning of the patient while doing the surgery. So I used to keep in 45-degree flexion. In that way, or the IMSC nail has to pass. So is there any way to, what is the position exactly while doing the surgery in this case?
We do it in a supine with a pillow under the knee.
Same.
But really speaking, the critical part of it is getting your entry point and the direction of the reamer and the nail in the distal fragment.
Correct.
Everything else is automatically directed by the shaft of the femur. So if you do the osteotomy at the right level, the nail is kind of going to go into the center of that fragment. And generally, I will tend to do the osteotomy a little higher or lower than the cora so that I get some amount of translation. And I'm not doing a pure opening wedge. That is one of the things. There are a couple of questions on YouTube. Dr. Ram Karthik asked, fixator assisted nailing with extracortical device can help here. In this particular situation, as Dr. Sharma pointed out, it may not be that easy because this is multiple osteotomy. If it was one single osteotomy, then yes, it probably could use that. But when you're doing 2 and 3 osteotomies, multiple osteotomies, using a fixator assisted nailing becomes that much more technically demanding. And Hemant is going to talk on that later. So we will surely hear more tips and tricks, and the limitations of what are there. Yashwant asks, any tips to accurately match and replicate your pre-op planning and osteotomy levels intra-operatively? Yes. One, as you saw, just can you put on your presentation there?
Yes.
Show the protractor. As I was saying just now, that the critical part is your distal femur. To get your guide wire in at the right level. So here we have this protractor which has been printed out on an OHP, zoomed in and printed out. So one of the people holds this on when we put in the wire, one of them holds it on the screen to confirm that we are going in at the angle that we want. Rest of it, as we pointed out, is at according to what the nail goes. You'll see another wire over there. Just with your arrow, can you point the wire, Vikram? No, with just, yeah, that one. So there, that is where we want to do the osteotomy, and that wire is at X amount of distance. Just show the planning. So on this we measure what is the distance from the distal end of the femur for that osteotomy, and we try and replicate that distance. So that's how we try and sort of ensure that we are as accurate as we can get. And despite that, as you will have noticed, we are not perfectly accurate. Dr. Ahmad Barzenji says three things. Since we don't have long leg X-ray intraop, can we depend on anatomic axis and anatomic LDFA? Yes, Ahmad, this is what I just showed on that, using that protractor. We are using basically anatomic LDFA as the line for the direction for the initial wire. While doing entry point through the notch, any tips on how to prevent chondral damage? I think some element of chondral damage will occur. What we do is we go with only a wire first, or rather a drill bit, so we don't move around too much. And once that drill bit is made, everything goes through that. Hopefully, with that we are minimizing chondral damage. But I don't think I can swear and say that no, we are not. But all the patients that we've done, none of them have had any symptomatic knee pain. And last question, Ahmad asks again, these stiff, straight reamers can be found in which set? Same thing, Ahmad, when you come to India after Corona, we'll gift you one. These are available in India. I'll send you just drop me a mail and I'll send you the address of the people who do that. So that was a good case. And I think now finally we get Divya to talk about the same thing, but a little more precise. And this should probably segue well into Hemant's talk of fixator assisted internal fixation.
Good morning, everyone. We'll be talking now about a proximal tibia deformity, which was corrected acutely. So this is a 27-year-old radiologist presents with the pain in the knee since about 3 years. He's finding it difficult to stand, work, especially doing ultrasounds and all. So he wanted some correction happening for that tibia deformity. The cause for the deformity was probably a growth arrest, or there was some growth there, which like an exostosis, but this was not like a hereditary exostosis. And he had this varus. Looks like proximal tibia procurvatum as well, but hardly any flexion deformity. The malalignment test showed that the femur was pretty all right, just that LDFA was 84, which is just a degree above 85. So MPTA here was the main culprit. And the sagittal views showed the PDFA was normal and PPTA was around 71, but there was no flexion deformity. So the question was whether we want any correction happening in the sagittal view as well. So the other issue was, again, he needed to resume work, didn't have any leaves left. So we wanted to fix it with internal fixation. And then the question of healing, whether an open wedge osteotomy or a closed wedge osteotomy. So we also did that planning on the trauma CAD. This is showing that open wedge correction, proximal mechanical axis, with the MPT as 87 and the distal mechanical axis. And the right image shows the planning for the nail. We did the tab plan 3D planning from those X-rays. This plan was made more for a neutral wedge, correcting both the deformities, getting into the oblique plane, found out what plane it is and how much wedge on the neutral wedge we would need to excise. This is showing the correction on the 3D, closing on the lateral and lateral cortex, small opening on the medial, and plan for the fixator. We could also plan for the nail here in the tab plan 3D. So here, what was more important was how we executed this. So we did the marking for the deformity. The joint line was marked with the K-wire under C-arm. One can see it here on the skin. And then with using a goniometer, marked an 87 line. This was also passing through the proximal femoral axis, which was the same, and a distal axis, anatomic axis, and a marking of the cora and osteotomy was done. So we used polar wires here. So this is the proximal polar wires, passed perpendicular in both planes. And these are the distal wires showing the white arrows showing the perpendicular two wires. Then we passed shank screws over these wires. The shank screws we were wanting to use as polar screws, also as a sort of standby if we need to use a fixator to hold the correction while we pass the nail, we even pass the nail. So showing the perpendicular shank screws there on the left image. Then we mark the cora and the ACA. So here we planned for the neutral wedge with the hinge just inside that concave cortex. And drilled for the osteotomy. That's showing the wedge there. And then the nail entry was made. This is the left image is showing a post-op image of the slightly bigger incision than the normal incision we make. Then through the drill bits, that's the osteotome which is going for that wedge, neutral wedge correction, directed distally and then proximally as well. This is a bone spike just to prevent that soft tissue damage. And then just that lateral cortex was removed. Nothing, no big wedges taken out, just that lateral cortex was removed, and rest of it was just closed with the force to compress the portion. Then the guide wire was advanced. Here now in the sagittal view, we were encountering issues when we were passing the nail, that it was hitting the posterior cortex initially. So we added more polar wires there. The orange arrows are showing the polar wires. But then when the nail was crossing the osteotomy, it was tending to pass. The red arrow on the left image is showing it's not central in the canal. The culprit there was this bone spike, which was not letting the translation to happen. So we added one more polar wire in the distal fragment to block that canal anteriorly, so that the nail goes more central in the distal fragment. And from then on, then everything went on smoothly. The polar wires guiding it through the center, and the white arrow there is pointing to the hand which is holding the distal shank screw as a lever to hold the correction in the frontal plane. So at the end of, once the nail had passed through the osteotomy, we had parallel aligned pins on both sagittal and frontal planes. And then the shank screws were removed and the nail was locked. With the cookie cutter, we got some cancellous bone, which was then inserted at the osteotomy. And these are the post-op X-rays showing the alignment as planned. The HKA there is 182, which is probably from the distal femur. The MPTA here is 88. So at 6 weeks, because this was done pretty minimally invasive, this was closed, lateral cortex is already healed, and the medial is healing as well with the cancellous graft. He had resumed his duties with, he was still on a pair of axillary crutches, elbow crutches, but he had resumed his duties. This is at 2 years follow-up with good healing and normal function and a happy patient. The learning points here are one needs to plan these acute corrections well and execute them also well. So one would encounter issues, especially with the proximal tibial osteotomies, to hold the fragment well. So the polar wires act as blocks. They control the direction where our reamer and nail is directed, and it also reduces the canal size, especially like in the distal fragment, where one would expect that it will follow the center of the canal. There the polar wire was blocking it and directing it well. One can use the fixator to hold the correction, but more importantly, it will help in the rotational control as well. And in proximal tibia, where we are locking, more than the transverse mediolateral locking, the oblique locking is going to help you to control, hold the fixation well. Thank you so much.
Thank you, Divya. So that is how, this is not exactly fixator assisted, but we had the pins in, we used the pins to signal the correction. Proximal pin parallel to the joint, second distal pin parallel to the joint. From outside, if I can see that those pins are parallel, I know my deformity is properly corrected. If we need to go back and hold it, we can still hold it. But despite that, even if we had held the fixator, inserting the nail itself creates some issues, which you have to be aware and look at which direction it's pushing the fragment, and then use the polar screws or polar wires effectively. Hemant made the point earlier about using DHS guide pins. Yes, we do the same thing. We use thicker K wires, 2.5 or 3 mm K wires, not very thin and flexible ones, so that they will serve effectively. And once the nail is in and has passed that area, then it's usually not a problem. And these are exactly the patients that I say are the most important for our learning. The patients who are demanding, either demand perfect correction or demand a quick recovery. They force you to think, okay, how can I achieve what the patient wants with the same accuracy that I demand? Getting this guy a little bit of valgus vagare would have served the purpose, but still, if I aim for perfection and then work towards it, that's how we ourselves as surgeons tend to improve. Hemant, I know you're going to talk expansively on this particular topic now, but any other quick thoughts that you have?
No, I think this is how, and I think planning is, we all keep on saying that the planning is so crucial, and execution can be tricky at times, but the only thing I would like to add is that cases gone very well, and the polar screws and the wires have to be used effectively. It will make your life, it takes a bit of time, but it helps you get what you want. In some cases, if your deformity is a bit proximal, and you think you might struggle, then a suprapatellar nailing sometimes can also be useful, because that you can do with patients sort of with just a pillow under the knee, and that makes your life a little bit easier to control the fragment. So that's the other thing I'll add. Any doubt, just go for the suprapatellar nailing, because you don't have to bend the knee as much to put your nail and everything. So
right. I don't know if Vasu is available. Probably not.
Yeah, Mangal. Yeah, I am just reaching Trichur. Yeah, it was a fantastic case of the most important part is most of the deformity cases are isolated cases. You may not get the similar case again and again. So by planning, we become more and more familiar to it. So many times you plan it. So we become more experienced. Each planning is like a surgery.
Absolutely. I think that
can perfect it.
Absolutely. I mean, that's a very important point. I mean, we didn't put it into as many words, and Vasu has put it into words, that if you plan this case 3 times in different ways, you are mentally executing that surgery 3 times. And therefore, when you actually go on table and it's the 4th time, you have already rehearsed a lot of the steps that you are going to do. And that's one very important aspect of planning, which we don't put it into as many words, that we think that, all right, we'll do it once. No, when we plan a case, it's been planned. Okay, what about this way? What about that way? As you saw, Divya showed, we planned it on TraumaCAD. We planned it on the other software, and you can plan the same thing on paper also. You can just draw the cutouts and then draw a straight line over there, effectively that is the same. Not that computer planning gives you any added advantage. You can do exactly the same with paper, but just because we do so many of them, it's more convenient for us to use the computer instead of doing it on paper.
And even the direction of the osteotomy also we try to change and work it upon that, so as to get more bone contact.
Correct. Yeah, like in this case, we said let's try and get excise a little bit of wedge so that it becomes more like a neutral. So it's not a typical 10 mm incision, slightly bigger than that, but just enough that we can get out what we want. Great. Yeah. So that I think covered a spectrum from what Jeejesh showed, only gradual correction and the problems that come up with that. What Yogesh showed of, again, some modification in the gradual correction. Vikram showed us internal as well as external fixation. And then Divya showed us only internal fixation. And many of us, I'm sure, are tending towards the use of internal fixation. But as I said, the goal has to be accuracy, which should be as good as what you can get with external fixation. So now I'll invite Hemant to share his tips and tricks and his way of doing things in terms of fixator assisted internal fixation. Hemant, all yours.
Thank you. So first of all, thank you so much. And it was Mangal, you've been so active academically all these years, and it's always good to learn so many things and tricks and from all my colleagues. And Vasu, thank you so much for a lot of tips in last few weeks, last few months actually. So if you see, Hull is somewhere from the north of England. If you take a Leeds, Liverpool, Manchester, Hull, they are at the same level. We are on the east coast. We are known for a number of things. We had the longest single span bridge in the world. Now it's the third longest. And there was a chap a long while ago in Hull called Thomas Smith. He started selling cod liver oil to hospitals. And then when his business grew quite a lot, about 50 years later, he actually asked his nephew to join him. And that's how the Smith Nephew company came about. So Smith Nephew was started from Hull. We still have the wound division. Orthopaedics has moved to US. So all the dressing you use in the entire world are actually made in Hull, which is not far from the hospital. Robinson Crusoe started from Hull, if you remember some of the stories from our childhood. We are a big hospital. We're a university teaching hospital. We are the major trauma center. And we have two big hospitals. One serves principally elective and oncology, and other serves, Hull Royal Infirmary serves the principally trauma. We provide all the services across the board in a hospital. Perhaps the most famous son of Hull was William Wilberforce, who fought all his life. He was a member of parliament from our area. He fought all his life against the slavery, and because of his, he was a principal person due to which the British Empire stopped and abolished slavery from its dominion completely. So I work in Hull. My name is Hemant Sharma. I work in a large unit, and I basically am limb reconstruction and surgeon, and I run a limb reconstruction bone infection service in Hull and the surrounding area. And I've been asked to talk about fixator assisted deformity, and I've taken the liberty of adding the navigated assisted because I think that's quite useful, something new coming out, and which would be quite useful to us. So I'm going to talk a bit about basics, including the osteotomy rules, the sites of correction, and try to give you my technique and some tips and tricks, and also show some cases along with to discuss the correction and how I go about it. So the principal question is why we want to do internal fixation, because I think the easiest thing is fixators, we love them. I tell all my patients that external fixator is the best device I have, but it is the worst device for you, because site infection pain is not easy. And therefore, I think if we can avoid fixator in some situations, it would be easier for the patients. The other thing is when we use the internal fixation, we need to take into account the deformity factors or the personality and the patient personality, and then devise an individualized treatment or the fixation device for that particular patient. This is an example of a 65-year-old lady who had a lateral OA. Normally you do a knee replacement. Knee replacement surgeons weren't very keen for this, and she was in terrible pain. She can't walk. And I did the fixator-assisted internal fixation. And the idea was to correct the deformity so she can end up having a knee replacement when she required. 3 years down the line, she's pain-free despite the arthritis, walking fine. So a lot of the times you can delay the knee replacement in such in these cases, but also important, this lady would have never tolerated fixator. Never tolerate fixator, the type of lady she is. So sometimes there are some what you call side benefits which from your primary procedure. So then the question comes in. We had a lot to talk about it, how to improve the accuracy, and the fixator is quite an excellent way of doing that, because it controls the situation once you've corrected it and you've got the desired alignment. I also use in addition a computer navigated assistant, because what we do is then we can measure the axis quite easily. There's no purpose-built platform as yet, and I'm after a number of companies to build it. They have the know-how, but they're not keen because there's no commercial benefit. So I end up using total knee replacement or HTO software to do that. The other way to look at it is get the best of both. So you do a 2-stage procedure. So a lot of patients where you want to then very accurate correction, especially the patient, what Mangal described, very demanding patients, you want to get it spot on. And in such cases, in stage 1, you can do your fixator, correct the deformity. And in stage 2, put the internal fixation and take the fixator off. And that is another way, although it's 2 surgeries, it's a very nice way of getting best of both and getting accurate corrections. The other advantage of this is that you can control the dynamic deformities which are not obvious on the table, because patient is not weight bearing. So I'm very keen on taking weight bearing X-rays and also taking weight bearing corrections to take dynamic deformities into account as well. And as I said, the principal disadvantage is it is 2 surgeries, and the infection rate is probably a bit higher, because if your internal and external fixation device touch each other, then that can be a bit tricky at times. But the incidence is quite small. What do we need to consider before we start? There are a number of things we need to consider. And the principal thing is soft tissue, what hardware you're going to use, and the vascularity, or how many levels you're going to correct, and the plant translation, because that will determine what implant you're going to use and how much would be the translation. So all this needs to be considered well before you even set out to do surgery, and therefore the pre-operative planning is very critical. How many osteotomy types we do? So you all know about it. It's an opening wedge osteotomy. You can have a closing wedge osteotomy, or you can have a dome osteotomy, which is my preferred method because of the bony contact if the translations are not too much, or because the small amount of translation you can is automatically happens because of the is a type 2 osteotomy. Level. So what you do is you plan your cora where you want to do the deformity. That is the ideal. But what happens in often you can't do the correction at that level, and therefore you have to move your cora, and you end up having Osteotomy Rule 2, and therefore they're always in obligatory translation. And therefore that you have to take into account, and when you're planning your correction, that what implant you're going to use. You must be familiar with the osteotomy rules, and for the sake of our although you know it, I'll just run through it quickly. So osteotomy rule 1 is when your ACA, your cora, and osteotomy at the same plane, then you correct the deformity without any translation, and both the fragments become collinear and they are realigned. And this is an example of that with no secondary translation. The advantage, you can use any implant you use because there's no translation. So this is ideal if you can do that. Osteotomy Rule 2 is when ACA is through the cora, but your osteotomy is at a different level. And therefore, there's this obligatory translation and bone becomes a bit zigzag, but both the segments are collinear and your deformity is corrected. And this is an example of that. So if you look in this case, there's an hyperextension of the knee because of the reversal of the posterior proximal tibial angle in a 17-year-old girl, can't do any sport or anything. When you draw your angles, you find the cora is very high. You can't really do your osteotomy there. So you do come down, you do osteotomy there. There's an obligatory translation, and you match the angles and you match the legs clinically, and she's back to full function in sports. The important is that you end up having, you're slightly limited with your implants. If the metaphysis is wide, you can use a nail, but in diaphysis, you will not be able to nail if the translation is too much. So you need to plan it out and work it out, which implant you're going to use. And the periarticular deformities where the cora is right at the joint, this is a perfect way of doing it. Osteotomy Rule 3 is when your ACA and osteotomy is away from the cora, and which basically means that you will develop a secondary translation deformity. It is usually a complication, but occasionally you will find that if there's a previous translation, you can use this to your advantage to correct the translation. When you're doing the corrections, it is an acute correction. So we must remember there is a neurovascular structures, and can we do the acute correction? Because there's a stretch on the neurovascular structure, and if the stretch is too much, you might end up with the problems, and therefore that needs to be considered and planned within your planning. And there, depending on the distance and the stiffness of the soft tissue, your stretching on the neurovascular structure will vary, and where your osteotomy is and how much you're doing, how much you're correcting. But remember, all these calculations are for normal soft tissue. If you have a soft tissue which is previously had scarred, you had previous surgeries, it's very tough. There's an incarceration of the nerves in the scar. Then these numbers don't matter. Then it becomes part of your clinical decision that if you think there is any doubts, you're better off releasing the nerve rather than not, because it is hard to have hard to control the problem once it has happened. And the best thing is to prevent a complication is to let it not happen in the first place. Then the question comes, how much you correct? And there is no set agreed examples of that, and how much we correct, we just all, depending on the soft tissue and a lot of other factors, we increase it and decrease the number. But there is some suggestion that if you're going to multiplanar correction and lengthening, then you should then you should be more careful. And again, I have these numbers from the literature, but it will all depend on the clinical picture. So I won't suggest that you use these numbers as a gold standard. Look at the patient, look at the scarring, and then plan it out and see what you can accept and what you can correct. This is an example of hypophosphatemic rickets. We were quite worried. So we did the release of the nerve. This is a fixator assisted correction, and we still use the frame because if there's any minor problems, we can always compensate in the tibia. What implants we're going to use? Plates, not ideal for diaphysis, and for metaphysis, they're pretty good. Diaphysis nails are good, but you need to remember that has to be you have to use the osteotomy rule number 1 for correction. Otherwise, there'll be translation and you won't be able to use it. Then closing wedge osteotomy, you all know it, but I'm going to just say a small trick that which I'm sure you all know it and do it. You put K wires, and each K wire is perpendicular to its own segment, and the total angulation between the K wires is to the magnitude of the deformity. You cut the put the saw inside the K wire, correct it, and take the wedge out, and then once you correct it, it's probably whatever is feasible. Both the implants are feasible unless it's at the level where you have to translate it, which is not normally the case in these situations. Dome osteotomy is my most preferred osteotomy. It rotates around a central axis of a cylinder, and it's always a tiny bit of translation, and because it follows the Osteotomy Rule 2. Bony contact is fantastic, it is stable, healing is much better. The only downside is it cannot correct rotation. There are special osteotomies. I'm not clever enough to do it, so therefore I don't do it. But if you can do it, plan it. If you have a 3D model, plan it on that and then do it so you don't get it wrong. But if it's a rotation, then I don't do a dome osteotomy personally. Where do you put the pins? And again, what you do is there are a number of ways of doing it, but if you put the pins out of the path of your implant, that's ideal. So if you're nailing a tibia, then you will see that you put the pins behind, so your nail can go. So your nail can go from here, and again here it is in the front, so your nail can pass through. And easily you can put in a wire through here, which will help you put the nail. So this is an example. This is a Rule 2, and if you see, it is these pins are posterior and these pins are interior, so you can put the nail through easily. The other thing is that if you're putting in a plate, then I put these pins on the opposite side of the plate. So in this case, you can easily put in a plate around here, and so you can correct it. But then, as long as you leave the space for your implant. So again, the planning is critical. If you're doing a femur, then you put the pins posterior, so you can put your guide wire and the everything reaming and nail from there. This is quite good for the proximal and distal tibial, proximal tibial and distal femoral osteotomies. And this is just a sawbone example that you plan it. You put the pins according to your plan, as Mangal pointed out earlier in the last case, which Divya showed, that you put in the pins and make them parallel. And once that is done, your deformity is corrected, and you will, and then you put in a nail or a plate, whatever you want. This is an example which Durai Naigam gave it to me, and this is LRS assisted deformity correction. So you put in your first pin, which is parallel to the joint, but then if you do the anatomical axis, which the question I think Ahmad asked earlier, is that we tend to correct a lot of it in the anatomical axis, then your lateral distal tibial angle is 81 degrees. So you put in a pin about in 10 degrees, and then when you put in your pins parallel to the second wire, and then correct it, you will get the exact correction. And this is the intraoperative picture, post-correction, and then you put in nail, and the deformity is corrected and mechanical access is straight. What type of fixators are assisted? One is hexapod assisted, which I'm not sure it's is good because it's quite expensive. It's for simple deformities, it's not worth it. It's a complex deformity, then yes, definitely. Most of my correction are through Elixir of hinge. Occasionally I do monolateral assisted, but I'm not very good at it because I didn't use LRS a lot in my practice, and therefore Mangal is fantastic with that. And if you're good at it, you can use monolateral. I've also started a unico assisted fixator deformity correction because it's a unicortical fixator. So I don't have to worry about where I put the pins, and I'll show you the example later on. Principles are pretty much same, whatever you use, and this is critical. But apart from preoperative planning, you need to follow the principles. So each ring or the LRS pin or whatever you're using should be aligned to its respective segment. Plan the osteotomy, you're going to do it. Preoperative planning is absolutely critical. You check your long leg alignment and you stabilize it, whatever implant you have decided to use it. And this is pretty much standard for everything. This is an example, a hinge assisted, where if you see both the, these are long rods which are going to the center of the ankle. This is going to the piriform fossa, is the anatomical planning, and put your hinge where you want to do it. And then once you've aligned it, and we all draw lines like Mangal showed in his case, he does. And then leave the space because it is a plating here. I've left the space for plating, and I'll show you another example later on as well for that. How to do it. So I'll run through my technique, how I do it with some simple steps. And so once you have planned and done everything, then you come to theater with your plan stick on the theater wall, plan A, plan B. If you're starting as you're new, make 1 or 2 or maybe 3 plans with the different bailout options, so you don't get stuck in theater. So this is a patient in theater. I mark my joint line, distal tibia, proximal tibia and distal femur, and then I put where my plate will end, where I put my osteotomy, and this is I'm going to plate it. So I've marked the length of the 6-hole and 8-hole plate. And what I'm going to do is I've made a frame with the hinge on it, and this is where it is going to. I'm going to put it this way. So since I'm plating, all this is open for me, and then the other advantage of this is I can plan it and see it on the patient before I start my case. Here, if you see, my pin is, both the half pins are out of the way. So even if I've used 8-hole plate, I'll finish it a little bit closer. Perhaps a pin here would have been better, but we were planning to 6-hole plate, so we thought it would be okay. 2 pins are on the medial side, and if you see 2 half pins on the medial side here, because what we're going to use it, we're going to use our, we're going to use the plate, so this space needs to be open. These are, just 1 second. These are computer trackers for the total knee. I use a B Brown system because that's what total knee hospital we have. But you can use any system. It really doesn't matter. So this is a tracker for the proximal segment, and this is the tracker for the distal segment. So you put it in place before you start, and you have to mark your hip, knee, and center of the knee and center of the ankle, all that, and that's the computer software does it for you. Once you've done all that, you align, which I've shown you, and then this was a closing wedge osteotomy. You put 2 wires, and this is the picture you get. So in this case, there's a 16 degrees of varus when I started, and when I finished, I end up with the 3 degrees of valgus. These are the pictures on table with the navigation, and this is navigation for the total knee. And once you've done that, I have locked my hinge here. And the advantage I use this way is because now my fragments are marked. And then I put in the plate. I actually show you how you use the, I double check the access as well before I put in a plate, or actually before I put in a plate, and then I put a single screw on the proximal and distal segment, stabilize the segment, recheck the alignment. Any doubts, I can take the plate out and overcorrect it, or if it's undercorrected, correct it appropriately, and then put the plate up again. And this is the clean leg with the finished product. This is an example where you see this is a young patient with a lateral compartment osteoarthritis, distal femoral valgus. And again, this is a computer navigated assisted. And I use a diathermy. So I use the diathermy which you use normally. So the center of the hip, center of the ankle. And this I wanted to overcorrect a little bit. So I've overcorrected it after locking the hinges. And then here you see there's the computer navigation images. So this is the valgus. And if you look at it, the axis is about quite a lot on the lateral side with that valgus. When I'm finished, this is my varus. And if you see, sorry, and if you see, my axis is there, which is about, my navigation is showing that about 30% in, which is sort of what I wanted in a kind of overcorrection, because she had a denuded lateral compartment, and I thought it might be better just to overcorrect it a little bit. It's the picture, and this is the correction, and this is the final correction with a 1-year follow-up, and this is what we planned for. She's still pain-free. She works in the hospital. Comes to see me now and again. Then you come to a complex deformities. When you have a complex deformity, you need to plan it a little bit more. And this is a lady, 84-year-old. And I said, listen, if I do something, you might die because you're elderly lady. I can't put in a frame. And she was struggling. She lives alone. She says, I'll rather die but I want my legs straight. So this is quite important for a preoperative planning. You do all that, plus you do the stress views of the knee, and we find the medial collateral is insufficient. So you have to take that into consideration in your planning, that what you're going to do for that. So my initial plan was to correct the deformity, and she had a lateral compartment OA. If required, we can do a stemmed knee replacement. You also need to check the hip adduction contracture. If there's any problems with that, you need to look into that. And also hindfoot, you need to look at it. There's no point correcting the leg with a fixed hindfoot, because that will put your hindfoot in the wrong place and patient won't like it. So all that needs to be taken into consideration. Spine, hip, knee, ankle, hindfoot. Is the deformity fixed? Is the deformity mobile? All that needs to be taken into consideration before you plan this. So this is my planning in theater. I planned it 1 neutral wedge, 1 opening wedge, osteotomy, 2-level osteotomy. This is my fixator, and you put it on patient. And this is a pretty good case for a suprapatellar osteotomy, because, nailing, because it's going to be difficult to nail with the fixator on. So you plan it, you correct it, and then you find that deformity correction comes out pretty nicely. And she ended up having a knee replacement after that, and walking pretty well, pain-free. Then I'll show you an example of a unico-assisted deformity correction. And again, part of it is surgical technique, part of it is an example actually. So there's a distal femoral valgus in a very young patient. And this is our trauma CAD planning, that this is what we're going to do. So again, the same thing, I mark my leg, I mark where we're going to do, I keep my fixator out of the way of my internal fixation implant. And so this is an exam. So this is, I'm doing this is the cuts for the dome osteotomy. You put in your pin, and then with a rancho, you just turn it around and do the cuts and do the dome osteotomy. And this is a unique fixator. So it takes about 15 minutes to put it on. This is an example. And if you see, these pins are just unicortical. So you put it on wherever you like, as long as they are out of the way of your internal fixation implant nail, or if you're using a nail, then out of the way of the jig, you put it on. And then basically, this one I put it in the tibia. These are the computer navigation markers. I do the osteotomy and then make the leg straight. And once you do the leg straight, it has a long rod like an LRS, and this is the diathermy method. I've checked my alignment on the patient, and once I've done that, hold the leg and then put in a rod and just hold the rod. And this is the rod which actually holds your correction. So it's a single rod, and it's quite sturdy, and you can basically lift your leg onto that quite easily. So once you've corrected it, check your alignment, put in a rod, and all you have to do is put in a plate. And this is the mechanical axis, quite a bit of lateral, comes to pretty much in the center. So this is your way of doing the unique or the unicortical fixator correction. And these are the final pictures of the patient, pre-operative and post-operative. Then how to sort of plan it, some basic things which we'll all know about. If you're putting pins medially, put the pins medially for a lateral plate, put pins laterally for the medial plate. You can easily put a subvastus plate. Is quite easy. Liverpool group, Durai Naigam has described the submuscular plate quite easily. I have to say I haven't done many, probably one, but it's a very good technique. And there's a video of it, a cadaveric video, which will be releasing in time with which will be online, hopefully for you to see at some point if you want. If you're doing the nailing, pin the pins posterior, or you can use a unique assisted. And this is an example of a unique assisted that this fixator is on, and still you can pass your nail quite easily. And again, this is a fixator with the pin on. This is the total hip replacement with the first patient I showed you, and the pins are not touching the prosthesis. And these are some of the examples which you can. There's an example where we can femur, and the idea is that there's a polar screw here, and this polar screw, what it does is it just puts your nail. And the reason I'm showing you this is because if you see, the entry point is a bit lateral. So we planned and knew that entry point is a bit lateral. So put in a fixator assisted correction, put a polar screw, and then started with that starting point, which was lateral. And one of the worries which was pointed out initially was a chondral damage. It is slightly lateral, so we were fine. Patient hasn't complained any problems and he's fine. But yeah, that can always be an issue. This is an example of a two-stage procedure and how to do it. So this is again young patient with he's a 40-year-old with middle compartment OA. It want to do HTO, but because of his job, he can't take a time off a lot. So we decided a two-stage procedure. Here we put in a fixator, and this is in a hexapod. I'm sorry, there'll be with no hinges in my practice unless a registrar specifically asks for me, a trainee. I normally put hexapods because that just makes my life easy. So, and I'm happy to put 1 or 2, sometimes 3 hexapods on the same leg. It's a bit tricky, but you can do that. So, so this is the correction. And if you find no X-fix pins on the medial side, and how I plan it, so these are the rings I use. So it's a 5/8 and a 3/8 ring. So 3/8 part is on the medial side. So I can take it off to put my plate on. So this is how I plan it. So the same way, if you see, this is the 3/8 part here, and there's nothing medially, nothing at all medially, no pins in the entire thing. And all the pins, if you see, are concentrated on the lateral side. If you're going to do a two-stage, you must plan it and plan the fixator accordingly. And 4 weeks later, all I had to do is I put some trauma struts and stabilize this segment, take the struts out, take this ring out, put in a plate, and then basically he healed up quite nicely because and he went to job pretty much immediately after the second surgery. Disadvantage: it takes more surgical time, and the thing is that it is, but the accuracy is good. So surgical time, that way side of compromise. If you're doing a 2-stage, then there is a second surgical procedure as well. There's a rebound phenomena which happens if the muscles are strong. So you need to be careful sometimes, because your plate on its own, especially a single plate, may not be useful. So you need to look at it. Either you overcorrect it or use a double plating. Recently, I did a case which on table, it was, despite correction, I couldn't hold the correction, so I had to put up 2 plates, which can happen at times. You only can do it once. There is no option of post-operative manipulation. Therefore, please take all your effort in pre-operative planning and execution of the surgery and checking it, so that you do not have to do post-op manipulation. I have to say, despite all that, it sometimes does happen. And this is an example where I did a correction, and on the table, if you see, it's looking quite nice. The correction is pretty much spot on, and this is the plate. But when I finished, and then look at the axis, it has gone back a bit, so it's undercorrected. It's a bit disappointing. Patient is pain-free, which is fine, but it's disappointing from the surgical point of view. So in summary, it's a very good thing for metaphysis, because you got a wide area, you can translate, you can put a nail, you can plate, works very well. Hardware is a principal issue, that what you're going to use, you must ensure there is a compatibility with the fixator, whichever one you're using, and there is enough space for each system. If there's any doubts, put it on a sawbone and check it, because the new nailing systems have got massive jigs, and they sometimes can come in the way, and you can't do it. Even for some plates, the jigs can be a little bit tricky, especially with the locking plates. So you need to ensure that both the systems are compatible, there's enough space for that, so you do not lose out, so you don't struggle in theater. And this is the most critical thing. Follow the principles of the deformity planning, and the pre-planning is absolutely critical. And that pre-planning includes not only your surgical correction and your implants and the hardware, but also your planning of the hip, knee, ankle, and hindfoot. There's any fixed deformities or any mobile deformities. If the fixed deformities, they need to be addressed at the time, or actually patient be informed that you need a further surgery to correct that deformity. You have only one bite at the cherry, so try as best as you can. Thank you very much.
Thank you, Hemant. So that was literally, I think today's kind of inadvertently also, to a certain extent, it got planned that, we were going to have a deformity correction theme, and you chose something related to deformity. So I think this whole 2.5-hour session is a good comprehensive look at the treatment of deformities. And a couple of things that I picked up good is the use of rings rather than unilateral frames with the 5/8. Also, that concept of the Unico, which is not available here, but I'm sure something like that, can be used or thought of manufacturing here. And that the final thing which you talked of in terms of the what was the word you used? Sequential, right? Where you do it with the fixation, confirm with weight bearing, and that actually gets the best of both worlds. That you have the accuracy of the fixator in a weight bearing situation, and you have the convenience then of internal fixation. Don't have to keep worrying about the fixator and things like that. So that was a lovely comprehensive talk. Exactly, this is what I kind of mean by a mentor talk, where the mentor has certain crucial kind of tips and tricks, which will be useful, well, in this case, not only for trainee surgeons, but even for experienced surgeons, as to how somebody else, does these things and ensures the accuracy, which is always a problem for us. So that was very good. Thank you. I'll just check if there are any questions on YouTube. No, there are no questions. I think basically your talk was pretty comprehensive, starting from very, very basic to the most advanced. So I think that has explained stuff to people. So I think we'll wind up. Vasu, anything?
Yeah. The talk was fantastic. As you said,
thank you.
From basics, and there is some learning point for everybody.
Yeah, that's what I said. Even we have, trainees will definitely pick up stuff. Even we've picked up a couple of points ourselves. So great. So I think with this, I will wind up for today.
Yeah.
And
thank you very much.
I will see all of you all in October on the
It was excellent, Hemant.
channel.
Thank you.
It was excellent,
All
Hemant.
right.
Thank you. Thank you.
Thank you.
See you then.
Bye-bye.